David Spigel. I'm the Chief Scientific Officer at Sarah Cannon Research Institute in Nashville. So we are showing the results of a study called AIM-HIGH. The whole goal of this study was to see if you could risk stratify patients with early stage non-squamous non-small cell lung cancer, a group of patients that can still have a high risk of recurrence, and we don't always give adjuvant therapy to. And so could you use an assay, in this case a 14-gene signature from a company called Razor Genomics, it's called Risk Reveal, to identify patients with intermediate or high-risk disease and stratify them or randomize them, to adjuvant chemotherapy or observation. And so this study was designed to look at patients with early stage disease, stage 1A, 1B, 2A, non-squamous non-small cell lung cancer. Everybody had surgery, and then everybody underwent this 14-gene analysis. It takes about 10 days to get back. This assay, by the way, was already prospectively validated in two studies, one over 1,400 patients, one 250 at a single institution, published in The Lancet in 2012. And that assay then discriminated patients with low-risk disease. Those patients have such a great outcome, they're not included in this study. And then patients with intermediate or high-risk disease were randomized to either observation or four cycles of platinum doublet chemotherapy, investigator discretion, cis, carbo, PEM, taxane, etc. And then the primary endpoint was disease-free survival. What's important to note about this study is it was stopped early because of strong efficacy signal. So the DSMB stopped the trial early after about a little under 100 patients in the experimental arm and a little over 100 patients in the control arm, well balanced. And the 24-month disease-free survival, as shown over here, was strongly in favor of the patients who got adjuvant chemotherapy. So remember, these are all patients with intermediate and high-risk disease, and the hazard ratio for benefit was 0.22. In other words, a 78% reduction in the risk of cancer returning or death at the 2-year point. And so the study was stopped early. This is quite remarkable finding because now we have a way to risk stratify patients in a way that we do for breast cancer and colon and even prostate cancer. And this now, I think, is a tool that doctors and patients can use to help make decisions about whether they should get adjuvant chemotherapy. I think if you already know your patient doesn't want chemo or you don't think they need chemo, you wouldn't do this. If you are sure you're going to do chemo, you wouldn't do this. It's those patients in between where you're not sure what to do to stratify them by risk. And if you have high risk, adjuvant chemotherapy can benefit them in a remarkable way.